Hi, everyone. I'm Amani Politano. I'm a vascular surgeon at Oregon Health and Science University at Portland, Oregon. Today, I'm going to talk to you about visceral artery involvement in vascular Ehlers-Danlos syndrome. As most of you know, vascular Ehlers-Danlos syndrome is an autosomal dominant genetic disorder of collagen production with over 700 mutations identified in the type 3 procollagen peptide. This results in abnormal production of the trimeric collagen module. Clinical manifestations include dissection or rupture of the medium-sized arteries, intestinal perforations, uterine rupture, and thin skin, easy bruising, and poor wound healing. In 2005, the Mayo Clinic published their experience with vascular Ehlers-Danlos syndrome over a 30-year period. Over that time, 31 patients presented, of which 84% had a history of a complication from Ehlers-Danlos at the time of their presentation, most frequently arterial rupture. In this group, followed longitudinally over time, freedom from any vascular, uterine, or intestinal event was 84% at age 20, and became 37% by age 40 and only 4% by age 60. Vascular specific event-free survival was 90% at age 20 and dropped to 39% at age 40 and 20% by age 60. Of the patients identified, 24 had a subsequent arterial event. These were largely arterial dissections or ruptures. There were very few true fusiform aneurysms, and 10% of patients presented with a cerebral aneurysm. The distribution of arterial beds is shown here, and of the 132 arterial complications in this cohort, 30 involve the visceral vessels, most commonly the celiac, trunk, and its branches, followed by the renal arteries and the SMA. To help illustrate treatment of visceral artery disease in vascular Ehlers-Danlos, I'd like to share a case. This case was presented with the permission of the patient, and we'd like to also thank Dr. Shalhoub and Black for their guidance in the treatment of this patient. Our patient is a lovely 30-year-old woman who presented with the advantage of a known diagnosis, specifically a genetically MIN or minimal mutation. She had a history illustrative of vascular Ehlers-Danlos with the items shown in bold in this table, including spontaneous pneumothorax, prior colon perforation, and bilateral internal carotid artery pseudoaneurysms that have been medically managed. Her family history was also notable for 2 first-degree relatives with vascular Ehlers-Danlos, both of whom passed in their early 20s. On initial presentation, our patient had nausea, emesis, diarrhea, lightheadedness, and subjective fevers. Early imaging was suggestive of a hemorrhagic pancreatitis, which was initially treated conservatively, but she developed persistent abdominal pain, and a repeat CTA was performed, demonstrating the aneurysms as seen on the left of the screen. She was managed conservatively with blood pressure control, and a few days later had a follow-up CT scan, this image on the right, which showed minimal change in the vessels, and she was discharged home. Several days later, she presented with recurrent pain, and a repeat CTA was performed, which showed enlargement of these aneurysms. She was therefore transferred to our institution for further management. She had an elevated leukocytosis, but no other lab abnormalities, and was initially managed in the intensive care unit with blood pressure control while we planned our surgical approach. Surgical management was indicated based on both her persistent symptoms and the rate of growth of the pseudoaneurysms. We selected a hybrid approach utilizing surgical vessel exposure and a combination of onyx and coil embolization of the aneurysms. We planned for several contingencies in the operating room, including positioning the patient for possible retroperitoneal exposure, performing wide prep, and having present various balloon occlusive devices and aortic stent grafts in case rapid occlusion of the celiac trunk was required. Surgical exposure of the left common femoral artery was obtained, and a pletited purse string suture was placed. The artery was accessed through this burst drain with a micropuncture kit, and a 5 French sheath was placed, which was ultimately upsized to an 8 French sheath because of a small tear in the artery that required the larger sheath to obtain hemostasis. A VS1 catheter was then advanced and shaped over the aortic bifurcation to avoid additional intimal trauma, and then used to select the celiac trunk. This was then cannulated with an 014 system, which was used to gain access to the splenic artery aneurysm. Next, a 4.5 milliliter Onyx 34 injection was performed into the splenic artery aneurysm, which was seen to fill the proximal left gastric, common hepatic, and right phrenic arteries, as seen here. The microcatheter was then slightly withdrawn and repositioned into the celiac artery pseudoaneurysm lumen, and concerto coils in 10 to 14 millimeter diameters, all 30 centimeters long, were used to embolize this aneurysm. This approach was selected to avoid significant manipulation of the distal portions of the splenic artery aneurysm, reducing the potential risk of rupture, but also to avoid onyx extravasation into the aorta. Completion imaging showed exclusion of both the celiac and splenic artery pseudoaneurysms, with persistent filling of the left phrenic artery, seen here. Hepatic artery perfusion was maintained through a replaced right hepatic artery off of the superior mesenteric artery. Follow-up imaging prior to the patient's discharge and on an outpatient basis for now over 1 year from her index procedure have remained stable. Several larger series and case reports document treatment of visceral artery pathology in vascular Ehlers-Danlos patients. Oderick et al. At the Mayo Clinic's 31 patient series reported on arterial events. Patients treated operatively for visceral arterial disease included ruptured hepatic, splenic, and ileocolic arteries, renal artery aneurysms, and renal artery dissections. These were treated with a combination of interposition graft placement, splenectomy or nephrectomy, laparotomy for abdominal compartment decompression, and arterial ligation. Additionally, in their series, a ruptured splenic vein aneurysm in a vascular Ehlers-Danlos patient was treated with endovascular embolization. The Vascular Low Frequency Disease Consortium evaluated patients with vascular Ehlers-Danlos over a 15-year period across 13 institutions from the US, Germany, and Brazil, and focused on 86 patients with molecularly confirmed diagnoses. Of these, the mesenteric arteries were involved most frequently in 31.7% of the population. Specifically, the celiac was most commonly involved, though the splenic artery was most often ruptured on presentation. The majority of these cases were managed medically, and surgical intervention was performed for rupture or pseudoaneurysm enlargement. Most of these were performed with endovascular embolization. One hepatic artery was stented. The renal arteries demonstrated equal distribution of rupture and aneurysm on presentation. And again, most of these were managed medically with one embolization, one artery that was actually lysed for thrombosis, and one splenectomy performed after a procedure. From this series, a total of 53 visceral events were described. All celiac pathology was treated non-operatively, and all of these patients presented with a minimal mutation. Hepatic arteries were involved in 10 cases, of which 7 were MIN and 3 were haploinsufficiency mutations. 2 of these were treated with coil embolization for ruptured aneurysm or intraparenchymal rupture. Splenic artery involvement was seen in 18 patients, again, mostly MIN mutations. The majority of these were treated non-operatively. 4 aneurysms greater than 2 centimeters were coil embolized, and 2 patients underwent open exploration and splenectomy for ruptured arteries. SMA involvement was only seen with minimal mutations. One ruptured artery was ligated with concurrent hemicolectomy, and one dissection treated with a bare metal stent. And finally, renal arteries, again, mostly MIN mutations, were largely treated non-operatively. There was one patient without a diagnosis prior to presentation who had FMD-like changes and who underwent an attempt at open repair with subsequent nephrectomy, as well as embolization of an aneurysm and one open repair of a ruptured artery. This was the only patient that suffered mortality from their procedure in this setting. In this series, endovascular repair was performed in a total of 19 cases, and complete percutaneous access was obtained in 14 of these patients, with sheath sizes no larger than 7 French. Closure devices were used in 5 patients without a reported complication, and the other 3 patients had an open vessel exposure to facilitate endovascular repair. Brooke et al. From Johns Hopkins University have reported on their technique of open access for endovascular interventions in vascular Ehlers-Danlos. In their large series of all presentations of Ehlers-Danlos, 9 patients presented with vascular Ehlers-Danlos, and 3 of these underwent endovascular procedures, including embolizations performed under either general or local anesthetic. All of these patients underwent an open femoral artery access according to their preferred technique, which includes a pledgeted purse string suture placement on the vessel, minimal sheath exchange or manipulation, and then closure of the purse string with sheath removal, followed by circumferential felt reinforcement around the vessel. I've mentioned a little bit of the genetic predisposition for vascular Ehlers-Danlos. Briefly, there are 2 variations of mutations, the MIN mutations or the haploinsufficiency mutations. These can be distinguished by whether there's production of an abnormal procollagen molecule, as in the MIN mutations, leading to a 7-to-1 ratio of abnormal to normal collagen, or an early termination of the procollagen from one allele, leading to a 1-to-1 ratio of normal to abnormal collagen. In a French Nations Reference Center for Rare Vascular Diseases paper, 215 patients evaluated for their molecular diagnosis were noted to have a significant increase in aortic complications in the haploinsufficiency mutations compared to the MIN mutations, including the glycine substitutions or the splice site variants. In this study from the Vascular Low Frequency Disease Consortium, looking at 173 individuals over a 15-year period, diagnosis was confirmed either by genetic testing, skin biopsy, or by meeting the appropriate major or minor criteria. There were significantly more mesenteric arterial pathologies in the group with a confirmed molecular diagnosis compared to those with only clinical criteria. Renal artery pathology was also more frequent in the molecular group, though this did not meet statistical significance. There was no difference in age at presentation for either mesenteric or renal artery pathology. The total number of arterial events was higher in the genetically confirmed group rather than the clinical group, and survival was noted to be poorer in this group as well. In another paper looking at the molecular diagnosis of vascular Ehlers-Danlos, 68 patients were included. Of these, the majority presented with the MIN mutation, while only 9 patients had the haploinsufficiency mutation. As you can see here, aortic disease was significantly higher in the haploinsufficiency group, nearly 56% compared to 7%, while visceral involvement was much higher in the MIN mutation group, 23 compared to only 5 in the haploinsufficiency group. No patients who presented with celiac artery pathology had a haploinsufficiency mutation, nor were there any patients with SMA pathology. In a multi-institutional group from France, 5 patients with vascular Ehlers-Danlos were treated with percutaneous embolization. These procedures were all performed percutaneously using either 4 or 5 French catheters, and one using a microcatheter directly through a brachial artery approach. These cases all included distal and proximal artery coil embolization, distal coil embolization with proximal artery glue occlusion, or glue placement only. The mesenteric vessels specifically treated this way included a splenic and a left accessory hepatic artery, both of which unfortunately ruptured with coil placement, requiring rapid infusion of the glue for hemostasis, and one patient with a renal artery aneurysm treated with glue who unfortunately did not survive the procedure. In all of these cases, the access vessel was closed. The percutaneous access vessel was closed with manual pressure. This image demonstrates the left gastric artery pseudoaneurysm treated initially with coil placement, followed by glue embolization with successful exclusion of the aneurysm. In summary, several adjuncts aid in treatment of patients with vascular Ehlers-Danlos syndrome. Surgically protected clamps or balloon occlusion for proximal control, utilizing felt strip to buttress the sutures or the anastomosis, utilizing DDAVP to minimize bleeding, and allowing a postoperative stepwise increase in blood pressure control to protect the anastomosis from undue pressure and potential pseudoaneurysm degeneration are all useful adjuncts. The Washington group advocates a fall back clamp position to avoid repeat clamp placement at the same location on the same vessel. For lower extremity or upper extremity work, tourniquet occlusion may be safer than clamp placement. Medical management with beta blockers is encouraged, and postoperative taking care of pain and making sure that bowel movements are facilitated help with recovery and reduce the risk of intestinal complications. Finally, use of a power injector during endovascular procedures has been associated with arterial dissection or rupture and should be used at either lower pressures or not at all. Surgical morbidity from operative repair is not unsubstantial in these patients, with bleeding and reoperation, most often for bleeding, at over 30%. There's also a risk of pulmonary complications, renal failure, cardiac complications, brachial plexus injuries, postoperative ileus. Mortality has been reported to be as high as 30% after an open operation and 24% after endovascular surgery. Up to 60% patients treated in a miscellaneous treatment group also had mortality in the odor-rich series. Medical management is generally the preferred treatment, even for visceral artery involvement, unless there's a presentation of rupture or enlarging aneurysm or pseudoaneurysm. Knowing the specific genetic variant can help predict the patient's most at risk and the most at risk vascular beds and help guide surgical treatment. There have been several studies now demonstrating that endovascular treatment of visceral artery pathology can be performed safely. Specific adjuncts, including coil, covered or bare metal stent placement, and glue or onyx embolization, have been successful, as have both percutaneous and surgical access sites. Thank you very much.